Welcome you. My name is Alexa Eggleston, and I am the Substance Abuse and Addiction Director for the Council of State Government's Justice Center, and will be your moderator today. So I'll be introducing our panelists and sort of making the discussion move along. And I think we do want to make sure we have a very sort of interactive, sort of free-flowing discussion today. So at any point when you have questions, that is definitely the focus of this session. So I think we look forward to hearing from our experts. They're going to open with some very brief overview comments about their areas of expertise. And then we're going to spend some time going around the room, sort of hearing from you, hearing who you are, and sort of what issues sort of are popping up for you, and concerns you might have, areas where you feel you need more information. And again, look forward to just a very rich discussion. So with that, I think I'll introduce Laurie Reid. Laurie is Captain Reid, perhaps, is from the Center for Disease Control and has a background in correctional health. She's a nurse by training and has worked in corrections. I think I always hate dating people, but over 20 years experience sort of working behind the walls and in the community around health issues with a particular focus on HIV, AIDS, and other infectious disease. After that, we'll hear from Dr. Osher, who is also one of the leading experts in the area of mental illness and co-occurring disorders, with a particular focus on how you help individuals with mental illness divert from the criminal justice system, and then once they're there, make sure they're getting access to the care they need while incarcerated and then upon release into the community. And our third presenter will be Dr. Faye Taxman, who's out of George Mason, who is a criminologist by training, but has a particular focus on health services, and she'll be talking about that aspect as well as sort of how you work with the individual as they're coming back into the community, engage them in the process, get buy-in, so that's a sort of proactive approach to transitional services and community supervision. So with that, I'm going to have Laurie open with a few brief comments. We'll go to Fred, and then we'll go around the room to hear from you.
Good morning.
Good morning.
How are you? Thanks for being here. I'm just going to open with a few comments. In terms of thinking about on the other side of when inmates are actually coming into the facility, whether it be a jail or a prison, what we have found, and through the research has found, a lot of inmates come in, and when they are assessed, we do health screenings on intake, and we also do what we call health risk appraisals within about 14 days, whether it be a jail or a prison. Oftentimes, this is the first contact for many of our inmates that are coming in, because if you think about their risk behaviors and their lifestyle, health care is really at the bottom of the list. So oftentimes, it's not uncommon for us to hear, I don't have a primary care physician, I've never talked to a physician before, I've never even been to a doctor, let alone a dentist. So that is just one thing to keep in mind in terms of making a plan for reentry, where you almost have to be a gatekeeper to help motivate an inmate who is actually exiting, that if they do have a health condition or their health status is not exactly what it should be, that has to be a priority for them, because really what we found in the research, especially with the Urban Institute's research recently, is that if healthcare status or healthcare quality for them is not good, employment status is actually poor, which means they really can't sustain themselves on the outside. And as you can figure out, the recidivism rate for folks who do have some chronic health conditions has been found to be somewhat higher. Not necessarily the reason why they go back, but they do have a tendency to have a higher recidivism rate. What we will see, and what sort of the chronic conditions that sort of stand out, believe it or not, are asthma or respiratory conditions, hypertension around or cardiac conditions, these are more of the chronic care, and hepatitis. HIV is prevalent, and hepatitis is prevalent 2.5 to 3 times higher on the inside, not necessarily because of transmission issues, but because this is what they come with in the door. And one of the things I said yesterday is that you give me a high morbidity area in the country, and I will give you a jail or a prison that also have higher rates that probably would be, I would even say 5 to 6 times. I'm not a researcher, but I can guess, and I can tell you they're probably 4 to 5 times higher, because we have a tendency to catch the folks who are at risk for HIV a little bit more easier than public health, because we have a sort of what I say captive audience and a great public health opportunity. But with that, we have some other things that I can say that we'll talk about in later on, but I'll let Dr. Osher go from there.
Thanks, Laurie. And thanks everyone for the hard work you have done in the last day and a half, the 6 months preceding this, the year and a half to follow, and the work that you do in general. The reason that we all are at this table is that we understand how important health issues are. Welcome, Dr. Taxman.
Sorry, I thought it was a 10. I apologize, everyone.
We could really just throw you right out there now.
You could.
I'll let you catch your breath.
No, I'm all right.
All right.
You know me, Chris.
So we're really at this table today because health is such an important and relevant issue for the folks that you're working with in your grants, and that we believe that it's an important component of their reentry and their successful reintegration into community settings. As Laurie said, all the rates of illnesses are higher among populations that have found their ways to jail and prison. Faye is our expert on substance use disorders. I'll let her give you some of those stats. I was going to focus a little bit of my comments principally on those issues around mental illness and the overrepresentation of mental illness within criminal justice populations. So that we have done a recent study of 3 jails in New York and 2 in Maryland with pretty good methodology, and found that 14.5% of the men booked into jails met criteria for serious mental illness, and 31% of women booked into those facilities. 14.5% of the men and 31% of the women. Sort of the aggregate was 16.9% of folks in that study met criteria for serious mental illness. That sort of replicates studies that were done in the 80s and 90s. The women's statistic is actually a little bit of an aha statistic for all of us. Those are rates that are 3 to 5 times higher in men and 4 to 6 times higher than you find in women in the general population. In our state prisons, we find on average about 16% of those individuals meet criteria for serious mental illness as well. So, you have to then ask the question, well, what's that about? How is there something about mental illness that sort of creates criminal behavior, or what's going on with all that? And there are a lot of factors that explain that. It is not about the association of mental illness and violence. That's a myth that we want to debunk, and yet there are some factors that are relevant, principally co-occurring substance use disorders, so that of those individuals I mentioned, 3/4 of them have a co-occurring substance use disorder, and that drives people, it's an illegal behavior, into jails and prisons. It also is very destabilizing. Those folks that are duly diagnosed have high degrees of disability, don't do so well, and end up having difficulty kind of making it within community settings. Second factor contributing to that high overrepresentation, homelessness. So we have about 2 million people during the course of the year that are homeless in our country. About 1/3 of them have serious mental illness, 40 to 50% alcohol use disorders, 20% drug use disorders, about 20% co-occurring disorders, and that a homeless individual is pretty visible within our communities, often capturing the attention of law enforcement, not necessarily for violent crimes, but for some of those street crimes related to panhandling, shoplifting, urinating in public. Those things don't typically drive you to prison, but if it happens over and over again, and you have enough warrants out there and judges are getting fed up with seeing you, you could end up with large time at the back end of that history. Then the other factor that accounts for that is that individuals with mental illness, same charges, same sentences, longer periods of time in both jail and prison. So in a Rikers Island study, those without mental illness, about 47 days, those with about 217 days. In the Bureau of Justice Statistics look at it, those individuals with serious mental illness, 15 months longer in their prison stays than those without. Well, what's that about? Okay, well, a few things. One, they don't do well with in these environments particularly, and so they end up getting in trouble, losing their good time, getting added seg time. Secondly, folks are reluctant to send them out with no place to go and no services, so that parole boards don't want to send someone out to the streets necessarily without care, and that they end up getting hung back at jails because they're waiting for, as a condition of their release, access to an appointment that doesn't exist, and so those are factors that contribute. And then lastly, or not, the next factor to consider is that individuals with mental illness end up with higher recidivism rates than those without, 2 times. Basically, in many of the studies that are looked at. That's your issue, okay? And so there's a lot of factors that contribute to that. 2 principal ones that I'd like to raise for your consideration, and that's probably one of the challenges that you're struggling with: access to care. All right, so we've got about 45 million people that aren't insured in this country now. A lot of them have mental health needs, can't get in to see anyone without insurance except going into the ER in crisis and things like that. That's not very good prevention, not very good treatment. And then, if you are fortunate to have insurance or have access to care, when you get into the door, what you get doesn't look like what the science says you ought to get. So that the evidence-based practices that we know are associated with good outcomes often are not available to individuals when they get in and seek care. And so it's kind of for all those reasons that we're interested in understanding what your issues are on the front lines and working with individuals that have health, behavioral health, mental health, and I'll turn it over to Faye to talk a bit about the substance use issues in the population, and then I'll kind of return and talk a little bit about our committee work that we've done.
Okay.
Dr. Taxman, we've introduced you already.
Oh, thank you. Well, I really apologize. For some reason, it was in my head. It was at 10 o'clock this morning. So. Anyway, as Fred said, I'm Faye Taxman. I'm a professor at George Mason University, and I'm a criminologist by training. And so I approach this field a little bit differently because of my academic and career work. But, about 15 or 20 years ago, I started working more on what's called health services, access and utilization of care by criminal justice offenders, both in the substance abuse area, but also the segue to criminal thinking and other things that are important if we want to be effective in working with the offender population. And a lot of my work actually is in the domain of trying to improve the quality of probation and parole supervision, because I very much believe that that's an undervalued component of the criminal justice system. And certainly, I'm not sure what organizations you all come from, but certainly in a lot of settings, reentry hasn't even really involved probation or parole, which I think is something that we really need to focus in on. But to go to the issues about substance use disorders among the criminal justice population, you probably are all very aware. You hear the statistics: 60 to 70% of the offender population have lifetime substance use. And that is greater than the general population. What's more important is sort of the National Household Survey on Drug Use reports that the substance use the criminal justice population has 4 times the current disorder for substance use dependency than the general population. So about 36 to 37% of the probation and parolees out there have some sort of substance use disorder. If we break it down by gender, women also in the criminal justice system have much higher substance use disorder. About 50% of the women would classify as a DSM-4 dependency diagnosis, and about 1/3 of the men would classify as a dependency disorder. So we have a wide variety of use, and unfortunately, you guys probably know this more than anything else, but we did a survey of correctional agencies about 4 years ago, looking at what types of services are delivered, and it was, very revealing about the things that you guys see every day, which is access to care is very limited. On any given day in the U.S., about 7% of the offender population in prisons, jails, or probation and parole can access treatment services, substance abuse treatment services. Actually, if you're in probation and parole, it's down to about 4%. So, those clients fight to get in the door, even though they have higher disorders than, the general population. And this is, a consistent sort of struggle. The other big factor that we really need to consider is what we deliver in treatment in the U.S. For the most part, is at the low end of the intensity. So we're really providing services, outpatient services. They're much more geared towards people with substance use disorders substance use, but not abuse and dependency disorders, when in fact most of the population needs are at the dependency level. And so there's a very big gap between what we provide and what the client's needs are. But related to that, and these are kind of the 3 take-home points that I hope, is that, I realize, and everyone here knows how poorly resourced we are in the system and how resources are dwindling at a time in which we need them. But I find this is a time that we can really begin to think about self-correction of the system and using your grants and the opportunities to really work on 3 things that can really improve the quality of care. The first is the concept of evidence-based practices and evidence-based treatments. I think Alexa distributed the NIDA Principles book, which lays out kind of what the science is about, effective treatment services for people with substance use disorders. And what's nice about that is that, if your organization could pick 1 or 2 areas over the next 2 years to really focus attention on, you could really streamline your system to, improving the quality of care that people are getting. And so the type of treatment programs you're offering are very important, and the types of responses to non-compliance. And I'll draw my attention to that. I don't know how many people in here are supervision staff or case managers. Okay, so a couple people here. So, managing compliance is almost harder than getting access to care. And this is in any disorder. If anyone has medications they have to take on a daily basis, if you just ask yourself how many times you took that 7 days a week, the U.S. population basically has about 30% compliance with their daily medication. So, so we have to keep that in mind. But there are tools that you can use to help people kind of both motivate themselves and also, work on compliance issues, and those are called behavioral management strategies. And the NIDA principles, and there's a lot of supporting other material I can send you. We have a current study we're doing right now about using contingency management and reentry processes that are rewarding people. And what we know is that rewards work better than punishments, encouraging people, incentivizing people. You guys were incentivized to be here by getting your grants, right? Staying at this great hotel, things like that. So, following the EBP framework is one component that's critically important. The second one is focusing in on this notion about motivation and really altering the notion that clients come ready to change when in fact very few of us in life come ready to change when we're asked to do things that are not necessarily easy for us. I deal with lots of students who when I ask them to write research papers, they're kind of saying, I don't really want to do that, and you have to figure out ways to really help people, and there are tools to do that. So motivating people to change is an extremely important component. And related to that is this notion that, one piece that's often missing is feedback to the client about what their assessments tell you as a professional. You know what it means, and you may try to relay it to the person, but what we know from the science literature is that showing people assessment results and trying to help them understand that they're 4 times more likely to have a substance use disorder than the general population is a way of helping people sort of understand why we're concerned about that behavior. And very few organizations actually give feedback to the client on what their assessments are or why this staff are concerned about their behavior. They just tell them, and so there's a difference between telling someone and sort of laying out a picture and then helping the person make choices about what their behavior actually is. So thinking about those processes. And then the last point is one that is important is this notion of changing our relationship with the clients and really thinking about the case management or probation or parole officer having a relationship just like counselors have relationship. So everything we know in the therapeutic literature is that, you know, working alliance with the clients or relationships are extremely important. And there's increasing evidence within the criminal justice field that, you know, caring, trusting, fair processes in probation and parole officers can actually be very powerful in motivating people to change, and also in terms of reductions in negative behaviors. And so this whole notion about relationships is something I hope you really focus your attention on. And, you know, to that end, you know, if you're interested, I have a number of things which I didn't give Alexa, yeah, but in terms of kind of thinking about how to do this, some planning tools and some techniques and things like that. So, anyway, thank you.
Thank you very much. And so now that we've heard from our experts, we want to hear from you. So, let me
just sort of give a context for the type of support that's available and that you can consider and help us in designing. You all have heard about the National Reentry Resource Center, and that's a component of the Second Chance Act, and it's something that the Justice Center has been asked to coordinate to consolidate information in one place about what works for whom under what circumstances. And so that resource center structure is guided by about 10 different subcommittees, and the subcommittees are representatives from all over the country in all disciplines, and the four of us are on the health subcommittee. We met on Tuesday all day to think about how is it that we could be most helpful to you as grantees and then to the field in general, and that it comes in under the rubric of technical assistance, and that there are a variety of ways in which that can be delivered, and that the conference and peer networking is obviously one of the tools, and you're all engaged in that process at this moment. There is also the website that is being constructed and developed, and I hope you've had a chance to look at it. It already has a lot of good information. You can click on the health section and get a lot of the stats that we're talking about today there. And then there is the targeted technical assistance that would come in the form of meeting with you, you're talking about your grants, doing some site visits, and being responsive to the concerns that you have. But in trying to frame the kind of health area under the National Resource Center, we met as a group, and our charge was to develop frequently asked questions, and so we've got about 40 of those that we think the field asks most regularly about health, behavioral health, and that those are going to be posted soon. We were told not to be so wonky about the way in which we answered it and to kind of talk in English, and so we're having to kind of go back and make it English, but it'll come out soon. And then we were also asked to come up with what would be the 5 basic components of a health reentry plan. And so I don't know, do you have that still there? So try to get 20 people to get consensus on 5 items that should be in this. That took about 8 hours of our day, and we had 40 things up there, and we kind of boiled it down into these 5 areas, which we would like to sort of use as an organizing framework for the discussions to follow. We'd like your feedback as to whether we've got that right or omitted things or not emphasized the right components of it. We'd like some direction from you about, we're going to host 3 webinars over the next year on health issues, and what should they be? What do you need? What would you like to learn and hear about, and how should we sort of respond to that? So what we came down to in the 5 essential components of a health reentry plan is this unedited list here. Actually, this was 16 pieces of paper that are now on this one piece of paper. Screening and assessment, all right? If you don't look for it, you're not going to find it, and if you don't find it, you can't do anything about it. So on both the health front, in terms of entry into whatever gate the folks you're working with start at, mental health, substance use, screening, if it's positive, moving forward with an assessment, and then if there is an identified disorder that would respond to treatment, second, identify and matching treatment to the appropriate providers in a community, the appropriate level of care, the issues Faye was raising about kind of the intensity of care that's responsive to the condition that you've identified. That would be the second component of a health reentry plan. Third, and this is kind of a thread, and we thought, well, maybe this is the overarching thing, but then we brought it down as to an element, continuity of care, to ensure that what happens in the community gets conveyed inside the fence so that they can be picked up on and continued. What happens inside the fence gets conveyed to the outside, so there are information sharing issues that's a part of this. There are provider continuity issues that are part of this. There's assuring that the person gets from the jail door, prison door to their appointments, that they have enough medication to get from A to B. These are the issues that are inherent in that concept of continuity, and we waste so much of our scarce dollars by repeating and doing over and not sharing, and so it's a component of continuity that we want to highlight. The fourth is system and services integration. So we're the health committee, and we're talking in this hour and a half about health, mental health, substance use, but we've already mentioned homelessness and housing, the need for that, case management, and the supports that are necessary to kind of make that happen, the income supports and entitlements that you need to access, the peers that need to be involved. And so these are all housed in different systems, and that individual coming out is the least capable of integrating all of those. And so we have a role and a responsibility in thinking how the systems play against and with one another, and then below the system are the services, how we sort of bring them in alignment. A classic example, as I mentioned, co-occurring disorder. The evidence-based practice for that condition is integrated treatment. Well, that requires mental health and substance abuse to come together, and that's easier said than done. But there are a whole bunch of those integrated networks. We're talking about medical homes as a new and growing kind of entity within our states, and that the concept is that you ought to have one place that looks broadly at the service needs and clinical needs that you have and create that home for you. And then lastly is assuring efficiency and effectiveness of care. And that's a broad category that sort of encompasses, let's make sure we measure what we're doing to make sure it's effective, that we take those measurements and feed it back to the services so that they can, in a quality improvement fashion, do better and deliver a more effective set of services. Faye's raised the issue about the feedback to the consumer themselves so that they can be empowered to participate in their care and in shared decision making, which we can talk in a moment about, and that it's within that kind of category that we've lumped those set of activities. I forget, Alexa, where did we put, there's this little thing, healthcare legislation thing happening these days, and where that is in the...
I think a separate sort of, so we're also going to develop an introduction and sort of, I think, a separate document that really talks about healthcare reform, what opportunities it may bring for sort of the under and uninsured population, particularly as it relates to Medicaid expansion. I think there's a lot of hope that there's going to be, an entire population, in particular, of single, usually adult males without kids that have not been Medicaid eligible, despite being low income and having other barriers, that may now be eligible for some base level of Medicaid care, which will include mental health and addiction services, which again should have a significant impact in terms of the care people are able to access, and which obviously falls within sort of the financing arena. So I think that's another thing we often hear, that even if the services are there in the community, on paper, people aren't able to access them because of the costs that are often attached, are prohibitive for people. So.
Even though 2014 seems like a long way away, it's not, and that's when the implementation of the health legislation is required. Some states may do so earlier if they choose, and your grants end before 2014. We realize that. Nonetheless, you're going to be right there on the front lines understanding the importance of access to health care as one of the critical reentry supports that are necessary, and will have a role in shaping the way in which that gets rolled out within your state. So we wanted to keep that up there. So those are the kind of broad categories that we think ought to be part of a health reentry plan. And now I think we'd like to go around the room and kind of get just a quick sense from you about whether they're the right categories or not, whether you'd like to hear something more in another area, or there's a specific issue that you want to raise as a question, or you'd like to brag about the way you're doing this so well within your own projects and teach us a little better way of doing things. Whatever the mode might be. We did this yesterday in our workshop, and we got about a third of the way down this side of the table, and then we were running out of time. So we're going to try to make sure we make room for everybody's perspective. But also, we have not yet introduced each other. So if you could just say who you are and what project you're a part of, and what kind of particular health question or issue you want to make sure gets on the table, that would be a way we could sort of continue the networking that's gone on in the conference. And I'm looking at you.
My name is Catherine Burns, and this is my first week on the job coordinating the Jacksonville Reentry Center in Florida. And
so you've made no mistakes.
We are working with adult populations, but I was a project manager for the Savory project, so I'm going to ask a question in regards to that. One of the major issues that we faced, we had funding for substance abuse and many mental health issues, but the inmates, none of them were mandated to participate, and none of them wanted to acknowledge that they had an issue because they had been somewhat away from substance abuse. You know as well as I do, they can do that inside as well. But so they all had this misconception that they no longer had an issue. So what tools can we utilize to convince them that they do indeed need a support system for especially the substance abuse issues that they face?
Okay, so that's a complicated issue. But the thing you should know is that, actually from the research studies, more and more evidence is coming out about the importance of starting people, particularly that were opiate addicts, on methadone or buprenorphine before they leave. So as a preventative tool to actually, reuse after they leave, because we all know when people leave prison, they think that life is grand, and then, they, start engaging in risky behaviors. What I would say to answer your problem directly, though, is I would really focus on your substance abuse treatment providers and work on a motivational enhancement, where they look at their problem behaviors and even tie it into some discharge planning. What are their plans in the first day that they get out? Kind of a hypothetical. Who are they going to meet? Who do they want to meet up with? What do they usually do when they meet up with that person? Because you need them to connect to what life on the outside means for them, and what their, what their patterns were in the past. And so, what people often skip to is, well, you've used before, therefore you're going to use on the outside, but, the client isn't there. They're thinking about, I haven't used and I can control this. And so what you have to do is make the situation real for them. So I think, kind of working on that motivational piece and tying in to kind of how they're going to manage that first couple days when they leave, and might be a way of kind of helping the client see that, this is normal behavior. Oftentimes people, I guess Jim Inciardi, may rest in peace, who was a researcher, he used to always say, the first thing people do is they go out and they drink, have drugs, and have sex within the first 12 hours. And, because they're partying, that they're out. And so what you want to do is get the clients to see that's what most people do, and that's not in your best interest. So I don't know if that's helpful or not, but, something.
Could we extend that kind of motivational work beyond the substance abuse treatment community, and is there a way to sort of incorporate it into supervision strategies?
Well, there is a way of incorporating it into discharge planning and supervision planning. Again, getting the client to think about what that first week is going to look like, and who they're related to, and what they would want to see in their supervision plan. One of the things that we talked about yesterday is most oftentimes we tell people, this is what you will do, and everything we know is every time, even a 2-year-old, you can't tell them not to touch something hot. They want to test it out, the waters themselves. So the question is, can you actually get the client to make choices about things? And we developed a tool that we've been using in some probation and parole offices called the O-Self, where the client, it's just a checklist, and I'm happy to send it around to anyone who wants it. But the clients basically select what are the things they're interested in. Are they interested in parenthood, the kids they haven't seen in a while? Are they interested in their physical health, relationships with their spouses or significant others, religious issues, whatever the 10 most common things, and let the client select and help them work on a discharge plan to enhance those. And that's one way of also empowering them to begin to look at what their choices are. And then from a supervision side, it gives the supervision officer something to say, okay, let's work on these things you tell me you're interested in. When we did this in probation and parole, no one was ever interested in their substance use. First of all, most of them denied it, and they were already out. But they were interested in kids, and they were interested in, a lot of times they were interested in their physical health. And so you can tie those things into substance use. If they're interested in their physical health, then tying it into, what are their use behaviors, but, it's how you approach it. And again, focusing on what the person wants is a good starting point instead of what the system tells them. Sure.
There'll be plenty of more material in motivational enhancement therapies or specific techniques. Motivational interviewing really uses a lot of the dimensions that Faye's outlining, and so those will be available online as resources, and we hope to be able to provide that support.
And I don't know if you're probation or parole or case managers even in the prison are trained in some of these, but there's good resources out there to train people, and I highly recommend it. Not because they're doing therapy, and this is something that's very important to but because it's a communication strategy, and that's what, when I work with probation and parole agencies, that's my message. It's about how we communicate to people and encourage them to take responsibility. Unfortunately, I learned a long time ago, most academies don't train COs, or they don't train probation and parole staff on communication strategies at all. And it is their most important skill, because you can't build a relationship with people without sort of having that empathy, but yet also having clearness and direction in terms of what are, what's allowable, not allowable. It's a balance in there.
My name is Crystal, and I'm here through Volunteers of America. We have a facility that's a collaboration with Harris County in Houston, Texas, and it's a chemical dependency, minimum security rehabilitation. My background is mental health, so I spent 4 years in the mental health community, and now I'm working in the addiction community, and boy, it was a wake-up call for me. Very, very different philosophies, and so that's just something that I'm having to learn to sit back and listen and just kind of be supportive of my new coworkers and how they can handle some of these situations. We don't have any mental health services in our facility, and I find that it's really hard for me. And so unless you've already been diagnosed before you come in, there's nothing. So it's really difficult, I think, and there's nothing that I can really do about that.
So the reentry project you're working on, what is it?
It's a mentoring, strictly the mentoring program. Volunteers of America takes care of the therapeutic side, so they have their chemical dependency counselors and things. Harris County runs the facility. And so anything that's on the mental health side would come through them and not through volunteers. And so it's just an interesting balance. And so I think that's something, I think they're realizing it's a fairly new facility. I think they're realizing that they're going to need some things there in place. But one of the concerns that I have is just they get the health care, they go and they see the clinic, and they go to the eye clinic, but the lady that I'm mentoring, she's done meth for years, and her teeth are terrible, and she's in pain all the time with her teeth, and she's not able, because of her history, pain medication is not something that they're wanting to give her. And so she's just, was looking forward, she just got out last week, and she was looking forward partially to her out date just because she could get some dental care. And and this may be a localized thing, I'm new to the area, but how do we find those resources for dentists who will work on folks at a discount, or who will help out with organizations? Is there any sort of national or federal money, grants, anything we can look at for our folks in that respect?
I got a question, because
Yes.
I'm just want to make sure I understand. You said new facility. Is this a treatment facility?
It's a treatment facility. It's only been around about 2 years. It's
Okay.
it's just strictly a probation rehab. So the women that we have are in minimum security lockdown, but they're on probation.
Okay.
But it's a rehab facility. So Volunteers of America runs the treatment rehab. It's a therapeutic community, and then the Harris County provides the facility, the COs, probation.
Oh, okay. So it's almost like a day.
No, they live.
Oh, they
on
live
the,
there.
On
Okay.
in the facility. It's minimum security lockdown, therapeutic community where they come in. There's the family structure of the women in the facility, and so it's a little different.
So, you may want to talk to the sheriff's office in Harris County that runs the jail, because I learned a long time ago that jail has over 100,000 people on any given day in that facility. It's really gigantic. So, and I suspect their medical director there will have a list of dentists.
They do.
And I would really recommend connecting with them. They're, they've navigated, there's a lot of things to do there, but they've navigated quite a bit. And those kind of things, I bet they have a resource that you could really tap into in terms of local resources and stuff.
Well,
So-
it's a really amazing program. The lady who heads up the correctional officers there, she cares so much about our ladies. And she's hard, but she cares about them, and they know that. And so it's a great facility. It's just been an eye opener for me, coming in from a completely different perspective.
So you can see why we can't get around the table.
Yeah, that's what happened.
That's what happened.
Say something else.
And I want to jump in on 1,000 issues,
Right.
and then there's oh wow, we talk about the generalities of these 5 components of a health plan, and then you bring us a methamphetamine woman that got pregnant, can't find a dentist, and it's really hard out there. I did want to just can't avoid comment. You say we don't have any mental health work in that. Well, I don't want to put too much pressure on you, but you do. You're there, and
The capacity I'm in, I'm not allowed.
Understood. I'm only saying that we want to, as it relates to integrated care for co-occurring disorders, we want to demystify this. It's not rocket science. There are so much more that's in common between addiction disorders and mental health disorders than different, that many of the same principles apply, and it really requires an orientation to educate and provide that information in a way that individual can use. And there's a lot of different approaches, and Texas has done some of the interesting research about the importance of integrated treatment for folks coming out of prison settings. It's one of the few places where we have data to support that it actually might make a difference for those individuals in terms of their recidivism rates, and they have a co-occurring grant in Texas, and so there are resources out there that could come to play, but easier said again than done. So.
Hi, I'm Nancy Fisher. I'm the Director of Prevention Services at the AIDS Council of Northeastern New York, in Albany, New York. And we have been working in HIV, hepatitis, and STD prevention in state prisons for a long, long time, as well as in the community. And we've been finding that so many of the high-risk populations that we work with in the community have a history of incarceration. A recent history of incarceration, so that's kind of how we started getting into specific reentry services to kind of approach it from this end and to integrate things more. And what we've really been finding is that the service provider systems, as well as the clients, are not getting that connection. They're not really addressing the physical health. We have been finding that physical health issues have not been on the table at all. There is a system, relatively new, a few years, that some of the high-impact counties have reentry task forces, and that are really coalitions of multidisciplinary coalitions, and we had to go seek them out. And we really were the first time that bringing any kind of health issues, let alone sexual health and hepatitis, to the table. So I'm really happy to hear all of this, that you're really addressing physical health along with the substance use and mental health, because they are so tied in. And I think it just hasn't quite filtered down to the local level. And so sometimes we're just, and even with the clients, in their hierarchy of need, they're not looking at that at all. I mean, it's really jobs and housing, and then we have to kind of backdoor it in, like once you're stable with this, then we, let's talk about this stuff, or we kind of talk about it, in the meantime, let's do this, so that's all.
I find that interesting, and I'm not sure where the disconnect is, because I know that Dr. Wright has done quite a bit of work in New York State, along with connecting public health and correctional health, especially starting with health on the inside and really trying to link that care to the outside. So in terms of that sort of, and he actually is one of the few places where they do leave with HIV medication. They do.
No, I think that's for people who are already infected.
Right. Okay.
I think this is from a prevention end. I'm speaking from a prevention end. That it's not in people's radar at all, how there might be connections, why we might want to be talking about that, looking at those kinds of issues.
Well, the big issue is, not treating STIs,
right?
Which, I mean, the movement in terms of advancing HIV and AIDS care is really now beginning to say, okay, let's start with people who, have STIs, since that increases transmission and everything. So, but, these are notches in the belt kind of stuff, moving the field along.
I think one of the myths, it's not really a myth, is that one thing that we try to keep in mind, I'm putting them back on my corrections hat, is that I go back to the words that I got from Dave Thomas, and we were talking about. He's actually a correction physician is at Nova Southeastern, and he said to me, he said, corrections must and public health may. And the reason I bring that up is because in correctional health we have a legal mandate for health care, medically necessary health care, which has 10 different people can give you 10 different definitions of that. Notwithstanding, it's still go versus gamble, because it's not that important as most people think it is. But prevention is something that is not on corrections radar as much as it probably could be. And the reason is because a lot of it is with resources. It's enough for us to just do basic medical. But we do have, we are thinking more and more in terms of prevention, because at the conferences we're starting to really push that arena. And I hear what you're saying, and that's why I think it's really important when you look at collaborations, which always aren't natural for most people, in terms of public health and what public health could do in terms of prevention. And that requires bringing folks to the table and sitting down and starting with a conversation. What can we offer for you? And I know the physical part is being taken care of in New York. And the more I think about it, you probably are very much right on the prevention side. It's not as much in terms of behavior strategies and things like that. But that it could be just a matter of maybe having a conversation around public health and maybe some other CBOs, that may actually be able to offer that, and where do they fit in terms of reentry. But and not to defend corrections, but prevention. No, we have a lot of facilities that we don't do any of it at all.
I'm Kathy Howie with Server Youth Network.
I'm Laura Travachek from Server Youth Network in Des Moines, Iowa. And we're developing a mentoring program for the juveniles in our facility. And so in regards to mental health, we're just interested in mostly, I think, the continuity of care plan for them as they are in the detention center and then are in their placement, and then as they transition back into the community, so that we can provide our mentors with enough support so that they can just continue that care for them.
I'm also from Server Youth. I'm Leah. And I just had some questions about motivation, but I feel like they've kind of already been answered, so thank you for that.
Are you guys using any risk and need tools in your facility?
Yeah.
At the mentoring, your juvenile facility?
We haven't. We specifically haven't used it yet, but it is there. It's just not something that we've like got our hands on yet and been able to use, I guess. So.
Well, just again, my theme about sort of, kind of improving practice and taking this time to really kind of ratchet up what we're doing in the field of practice. Using a risk needs tool is a good way of trying to really see which of the kids' behaviors you really want the mentors and the probation and continuing care, placement facility to really deal with. And, I know mentoring seems like it's so separate, but, if you know what some of the factors are that really, get that kid sort of, out or continue in their negative behaviors, that's a good way of kind of focusing everyone's attention around what the targets are. And that's why, the EVP literature is about risk, needs, responsivity, _responsivity. We have to respond to those things. There's, these are human beings, just like all of us in this room. We all have our strengths and our weaknesses. The question with the, populations we deal with is which of those weaknesses that they have are really why they're doing what they're doing. Because, the needs are always much larger than we can address. But if we know what we're targeting, it's better. So, in your planning, you may want to really begin to think about working with facility people on that.
Are you a new mentoring program? Are you existing? Okay. Are there other mentoring grants here? Mentoring, excellent. Because I've had a chance to talk to some of the a few of the mentoring grantees who are very advanced, and I've actually been really impressed with sort of how much they've been able to do, in particular with partnerships around the community. So if you haven't had a chance to sort of network amongst yourselves, it might be something that that we can help with sort of after this meeting. And I can talk to some of them about, they've been around for a while and are using this money sort of to expand their services and really strengthen them. So it might be nice for you to be able to connect some of the newer people with some of the people that have been around, done it for a while, to sort of hear how their programs have evolved and how they've been able to take on some of those issues, which can be very complicated and very daunting, I think, when you're first starting out. So.
And you could also talk to Roger Jajora from the Mentoring Center. I think he did a presentation, but Roger, he knows a lot about risk needs tools, and he's really very good. So.
My name is Melissa Chrissy. I work at Open Doors, which is located in Providence, Rhode Island, and we have a adult mentoring program that's about 5 months old. So I've really just been doing a lot of program implementation, development, and starting our first matches. And my issue is just that it's not really anything I think that we can solve here today, but just the access to care issues, just seeing, meeting with people in the prison and identifying a lot of substance abuse and mental health needs. And when people are released, there's just such a lack of supports in the community, and the mental health system and substance abuse treatment system is so broken, and there's just a lot of the people we work with don't have health insurance, so they can't access care, and the care they do access is not enough. So it's just such a huge issue that unfortunately we can't solve today.
Have you guys talked about yet trying to play any role in terms of helping people figure out if they're eligible, how they would get enrolled, those sorts of things? Do you feel like that's beyond the scope of what you're able to do?
No, we have an access to recovery grant at our agency.
Oh, great.
The agency where I am, it's all reentry work, and we have the ATR grant, so we do help connect people with services, but there's been rumors that that's ending. I don't know if that's just Rhode Island or if that's national, but yeah, we do a lot of referrals. It's just like, I assume everywhere else, it's just everyone's very stretched, so.
Well, I think in terms of, the new healthcare dollars coming online and Medicaid expansion, that would be an interesting thing for some mentoring programs to think about, because enrollment is going to be critical. I think one of the things that we've learned about Massachusetts and their healthcare reform is that, the 8 or 9%, I think, that are still uninsured disproportionately suffer from mental illness and addiction disorders. And so, and I think large times it is because there's sort of a separated population and an alienated population. So to the extent that, you're sort of the people on the ground who are interacting with people, thinking through sort of what are enrollment strategies as this new benefit comes online. So.
And there's no way to fix the issues of systems that are underfunded and under siege and under stress. Nonetheless, you know, there is, I think, a need for the grant programs themselves to triage, you know, the people they're working with and try to figure out how to prioritize who would get that scarce resource, and that it's really critical that we think about assessments that allow us to say, you know, well, it ain't perfect, but this individual might do okay in a NA group a couple times a week, or better than nothing. And it's this person over here that I'm really going to push for an IOP program if I have one slot to fill. And that we want to make sure that we don't mismatch, you know, the level of care to the need that's there. And that doesn't fix the issue at all, but I think we got to be just smarter about how we use the scarce resources that are out there to get the biggest bang we can for the buck. And it's not a easy or simple situation, as you know.
Hi, good morning. My name is Whitney Kujawa. I just joined the Council of State Governments on Monday. So I'm kind of floating and learning, trying to learn as much as I can. My area of focus before I joined the council was with the International Association of Chiefs of Police, helping bridge the gap between community programs and law enforcement in the focus of gun violence reduction. We did dabble a little bit in a law enforcement response to the mentally ill, or persons with mental illness, I should say, and getting them to realize the difference of persons with mental illness versus maybe somebody completely high on drugs or drunk is very interesting. Their immediate response is to use a force or pull a weapon, use loud voices, but so we kind of struggled a lot to get them to realize that they needed some training in areas of recognizing persons with mental illness and how to maybe tell the difference between somebody who is mentally ill and somebody who is on a 10-day binge of cocaine, and how to react to that. So I'm glad to sit in and listen to this. It's very interesting, and try to relate it back to my work and continue that now. So I'm on the law enforcement team with the council. So thank you for having me.
Hi, I'm Bob May with the Association of State Correctional Administrators, also part of the Reentry Resource Center, and I'm really just enjoying hearing what the issues are that are at the top of your agendas, so we can better respond to those through technical assistance.
Awesome. Good morning, my name is Erica Ford. I'm a project coordinator for a recent reentry project that kicked off in 2009. We provide intensive case management pre and post release for our individuals, both those with mental illness as well as those without. Going into the prison, starting that treatment plan and developing the release plan for them for 6 months post or beyond, depending on the particular need of that person. We did receive the mentoring grant, so that's one arm of the services that we provide as far as the wraparound. We have currently about 39 agencies in our network that we work with for employment, AOD treatment, education, pretty much all the different barriers that everyone experiences upon release, healthcare. But I concur with a lot of the issues that people have discussed. We are funded through our county as well as the United Way and some local foundations, and we're only 3 years and we're only serving 440. So we're looking at how do we expand and how do we build capacity to do this for the long run, because while we're able to do this for this small population and we're showing it to be effective thus far, it's not available to everyone. And I guess sort of a lot of the questions have been answered for me thus far, but one question I have is just how can we, as a pilot project, looking at expansion and how we can replicate potentially in the future after our pilot is ended, connect individuals to those services, because in Ohio, many people are not coming out on parole anymore. They're being straight released, so they're not having the opportunity to be connected to the services, essential services that they need, like healthcare and mental health. So just getting feedback from the panel on how we can better equip our legislators to know how important it is that people are connected with services. The agency that I work for primarily does mental health services, so our clients are at an advantage because they're in this pilot project, but then they're going to be integrated into our behavioral health department. but that's not available for the entire population. So just trying to figure out how best we can do that, because as everyone has stated, these are all essential and they all reduce recidivism. So just some feedback.
You know, that's part of changing what discharge planning is now. And so, you know, discharge planning in most places is a misnomer. It's generally a piece of paper. And, you know, it's really about us taking a look at that process, because Ohio is not the only state. A lot of people opt out now. They'd rather not go on parole, and they'd rather do what's called mandatory releases. You know, their time's up, that's it. And, you know, their mindset is basically, I'm done with it. So the question, you know, that your system will have to address, and you may want to talk to Ed Ryan, who's in Ohio. I don't know if you know Ed, but he's great. He's with DLC, and he does a lot of reentry work. But, you know, and I know that he's working on a lot of changes in discharge planning. But if there's a facility that a lot of people come back to your community from, and, you know, you could also do some informational sessions at that facility to talk about the services that your organization can provide to people, regardless of whether they're on parole or not. And, you know, Massachusetts did this about 10 years ago. They actually, in some of their contracts, they required all the service providers to basically, you know, offer services to anyone who's coming out of prison, regardless of whether they're on parole or not. And the reason they did that is in Massachusetts, about 80% of the people leave prison without any, you know, papers or anything. So, you know, they don't have parole. And they realized those folks weren't getting access to services. So, you know, I think outreach efforts in-reach efforts into the prison is probably a good strategy, and working on the discharge planning where it's you know, the clients basically say, okay, if I were going to do this, what would I look for, and begin thinking about those things.
And I just also want to amplify the importance of the shared decision-making process, and you know, our preamble to our health subcommittee, 5 components will be, it's about the individual, not about the system or the services. At the end of the day, that person defining their needs and finding their path, and we're coaches, supports, and change agents in that process. Towards that end, and I work at a homeless clinic in Baltimore, and I have folks on paper and not on paper, and, you know, we're always struggling with how do we turn external motivation into internal motivation. And that one of the evidence-based practices for your group that you know of, I'm sure, and could amplify again, is illness management and recovery, so that there's sort of self-directed care, you know, in which they can work through a manualized approach to figuring out what's important in their lives and then actualizing it going forward. So ultimately, that's the key to this ending recidivism, is for that individual to own. I don't know how many people saw the Castle presentation yesterday, very powerful, but the common thread for me was just how they just said, this is my life, I'm going to take control of it. And fortunately, there were some supports there to allow that to happen for them, but I think that's another part of our strategies in working with folks that you know, may not have supervision or a PO hanging over their heads.
I'm sorry, I know we have a couple more people, but just to sort of encourage others in the room, because I know Captain Reid had mentioned just about getting everyone to the table. The pilot project that I currently oversee did not just happen overnight. It took about 2 or 3 years for the entire community to finally come together, sit down with all the different essential services. And I think the woman that stated that they need mental health services for their clients, I mean, you really just have to bring everybody in the room and have everyone really step up to the plate, because the services are there. It's just a matter of the integration. And even if you can't do, you know, a true like IDDT model where everything is under one roof, doesn't mean that they can't be facilitated for the individuals.
I'm Bill McCollum, a grants administrator at the Oklahoma Department of Corrections. I'm here to steal ideas from other places that improve what we're doing.
I'm Les Johnson from Arches in St. Louis, Missouri. Hi, Alexa. And we're administering or implementing an adult mentoring program in 2 facilities, one women's facility and one men's facility. And for us, we're not a direct service provider, we're an intermediary. So therefore, we identify the appropriate partners to bring to the table. And then with those partners, we charge them with specific scopes of work. And they actually are the ones responsible for doing the work in the community. We currently have approximately 15 partners around the table, a good mix of government agencies, faith-based agencies, and community-based organizations. And DOC at the state level and the local level are at the table. But what we find missing, and we've been involved in this work for the last 5 years, is access to quality mental health services. The community-based, because the community-based mental health providers are there. In many instances, they have one psychiatrist, one board-certified psychiatrist who rotates throughout the community. And so how do you provide the proper oversight to ensure that you have an efficient, that you're managing that process so that it is efficient and sufficient for the needs of the populations that we're attempting to impact. And typically, we find that we have the best results when we're able to contract directly with those service providers. That model works for us. We use a performance-based contract, and we get, the outcomes that we're looking for. When we're having to negotiate with community-based service providers, it's a little more difficult to manage the quality and continuity of care. So how do you get that done?
I like your one performance-based contracting mechanism, which was one of the things I might have suggested, and you're already there, but you don't have that lever with all of the folks that you're working with, it sounds.
Especially with this particular grant, because you're not able to pay for those services.
Right.
Yeah.
You're trying to convince and persuade.
Yeah.
I'm a psychiatrist by training, and I'll apologize for our field first and foremost. We have been very slow to appreciate and recognize our role as community partners in the service of public safety. Oftentimes we don't think that's within our purview, but that's changing as an organizational culture, not quick enough, but changing. And that I think that it has become increasingly clear to a starved behavioral health system that if they don't hook up with some partners that can actually provide and share resources, that their lives aren't going to get any better. And so I think it is the long haul, not a meeting or two, but the 3 or 4 year process of sort of identifying the common objectives and opportunities that exist for working together. That doesn't help your second chance grantee tomorrow, but you're in a great position with your history of work and a variety of different methods and mechanisms to be somewhat persuasive about the advantages of hooking up together. And it just is you're not alone in not having access to high quality care. That's not comforting, but it is the facts. So.
Well, and the other thing I guess I would ask, sort of, to what extent do you think that the providers who have been operating under the performance-based contracts feel like it's been successful for them and for their agency, and that it's contributed to, increasing quality? And is there an opportunity for sort of peer learning or peer sharing where they could maybe, have conversations with some of the providers that maybe haven't gone that route to talk about, maybe you're not going to be performance-based, but let's talk about some of the outcomes that we've seen by, taking some steps to improve the quality of our care. And I think if you can help sort of the providers see that it improves maybe their bottom line, that it improves sort of their quality of services, that maybe there may be some additional motivation there to take on some of those issues.
Yeah, we're also looking at, because we have not engaged the local mental health board in this process. They're a partner with us in some other initiatives, but not necessarily with this particular population. And so that's an additional strategy we want to try to employ. So, good suggestion.
Another strategy is to use the team approach, to have your team develop some quality standards for you. So it's peer driven. And what's useful about that is it establishes sort of a norm of what you all would like to see done.
Okay.
And then, it's like all the other partnership work. When you put out on the table and get people's expectations, everyone rises to the occasion because they know what people would like to see. And so, you know, even when you have volunteers, you know, the volunteers oftentimes, you know, they're putting this into the world,
Right.
and they're not thinking about, you know, all the other things that you're trying to manage as kind of running this. But it helps them sort of get another light about, oh, we can add in this way, and these are the things that can help. So, you know, you might want to think about some of those sort of strategies and doing in fun environments, you know, picnic or something like that, to kind of get the team spirit going, you know.
Here we've left 7 minutes for the last 7 people.
I'll be short and sweet.
No, sorry. Short time.
I'm Julia Vielig. I'm from the Government Accountability Office. We do policy and program research for Congress, and I'm just here to learn and absorb.
Hi, I'm Roland Laudenberg. I'm with Mountain Plains Evaluation. We're the evaluators for South Dakota. We have 2 grants. We have an adult reentry grant and a juvenile justice reentry grant. A couple of short comments on your 5 points that you have up there. A couple of things from my perspective that'd be very helpful is just some guidance around screening and assessment. What is good screening and assessment? What's good practice? I know you already have on your website some suggested instruments, etc., which have been very helpful. And then underneath number 5 in the kind of the measurement performance areas, it'd be helpful for some guidance there in terms of what are some ways, some standard performance measures. And I know we have the performance measurement thing later today, but that would be something that'd be helpful. And then the kind of one question is, Faye, you mentioned the motivation and looking at stages of change potentially, and just your thoughts on how do you measure that at different points in time and then integrate it into the treatment plan for your parole and probation agents. And you also mentioned that there was some research literature that supports integrating that assessment information into the case planning and working with the offender. What is that research, or is that available, or is there a way you can link it to your website for us? That'd be very helpful. And thank you very much for your time.
So can I answer one of the questions? So, and I'm glad you really asked this question a lot, because our work group on Tuesday, basically we had this very short discussion, too short, we need to go back to it. Yeah. But, you know, one of the things that the substance abuse treatment field has learned a lot, and actually you heard Senator Brownback say this yesterday, when he basically said to folks, you guys and us, that try something. If it's not working, don't be afraid to move ahead and try something else. Mm-hmm. And this is called rapid cycle in the, you know, process improvement literature, if you want the technical stuff. But and what's really important about it, it's all quality based. But you have to have an idea and measure about what you think the expected outcome should be. So one of the things, you know, the biggest issue in life is getting people to show up, right? I mean, you know, it's true for almost anything in life. And so in the substance abuse field, there was a group that got together, I don't know, 6-7 years ago, called the Washington Circle, that dealt with quality measures. And they came up with this notion that, you know, we want people to initiate care, and they were going to basically use the notion of initiation within 14 days. And they said if we could get substance abuse providers to go from assessment to first treatment session within 14 days, wow, we can change the field. And they have 200 sites across the U.S. that have actually, you know, are working on this as their main motivation. And I would highly suggest, if you haven't, you can go on their website, the Washington Circle website. It's www.washingtoncircle.com. If you don't get, if I'm wrong and my memory isn't well, email me and I'll get it for you. But they have initiation, they have engagement measures, and I think in the criminal justice field, I've been trying to talk to them about this, we need to develop our own standards on these concepts. And that's something your team can do for performance measures. Now that's not what BJA is going to talk to you about, because, you know, they have things that they have to report back to Congress, but those are longer term issues. So for the woman from GAO, thinking about these process things, well, because we got to work on the process. that's why we have so many problems with criminal justice clients, is we have unclear processes. So, you know, it's just some ideas, and I'm happy to talk to you about your other things afterwards.
And just, you know, the whole notion of integrating stages of change into supervision strategies is a terrific evolving field. There are sites around the country that are struggling with this issue. You can go to www.coce.com and see how that's been played out within the mental health substance abuse community. It's then a little bit of a leap into integrating into supervision, but it's a really important set of tools that I think gives us a more nuanced approach to complex change in behavior, and it's a very important strategy. I'd love to talk to you more about it. Please.
My name is Dave Williams. I am the evaluator for the Adult Reentry Project in San Mateo County in California. My background is as a clinical psychologist, and I've always been amazed by the lack of integrated care for folks with co-occurring disorders. So I don't have any specific concerns to raise today, and I can move on, but I just thought I would sit in and try to learn.
I'm Becky Wyatt, substance abuse counselor, Richmond City Sheriff's Office, the substance abuse tier, the belief tier, and I also have the great honor of working with our co-occurring disorder tier for the men, and I have found DBT to be excellent, dialectical behavior therapy skills training, excellent in dealing with the borderline personality disorders that I have on that tier, and combining it with relapse prevention, and it's working out very well. Thank you.
There's a in Montgomery County Jail, they use DBT, but the nice thing about it is that they have the providers do it both inside and outside. I don't know if that's your approach as well. But
absolutely.
All right.
It's working out really well. The most popular treatment center in Richmond, Rubicon, I get an opportunity periodically to go there, and as a result, they have now hired a counselor, and she's become skilled in DBT skills training. And I also work with a community-based, peer-driven program in Petersburg, Friends Against Crack, that my sister and I founded in 1998. So we use the skills training there for our community-based
So we'll
clients.
try to incorporate some of that into our frequently asked questions so that we can make sure the field understands its utility.
It is awesome.
Yep.
Yes.
Good morning. My name is Terry Butler. I'm the Second Chance Reentry case manager and substance abuse counselor for the identified population at the Richmond City Jail. And something that was interesting that you were saying as far as the lack of care that we have a psychiatrist now. How sick is this? We have a population for 1,400 inmates that comes once a month that sees, listen to it, it gets better, that sees 10 clients that we have to select 5 men or 5 women now, or it may be the month he just wants to see the men. And I have some women who, once their yolk has been burst, who has so much childhood trauma that I hate to even leave out after the group. And when I inquire about the services, oh, well, he won't be seeing the women for 2 months. And then you have to put your name in because he sees 5 women and 5 men. And after this woman has shared her heart, that I'm ready to pay for it myself. I mean, seriously, you know.
Can I recommend something?
Sure.
You know, VCU Medical School is right up the block from your jail. Right. And they have psychiatrists that have residency requirements.
Yep.
And, you know, one of the things that someone talked about, I think yesterday, is getting some of the medical students to begin to work with that population. And if you need, I know a lot of people, I used to be a VCU. I know a lot of people in the medical school, and I'm happy to work with you in getting some
Please.
because, you know, they are always looking for good internships.
Well, I will wait until 10 o'clock to get your information because, I mean, really.
It's not a problem.
1 minute.
Okay, I can wait.
But, you know, and I have a research staff down at Richmond, you know, who also, they could probably help you a little bit too.
Thank
Jim
you so
May-
much.
Jim May also at our.
Oh yeah, well, Jim May is on one of our advisory
Yeah,
boards.
But I'll talk to Jim. We'll talk afterwards.
Well, I need to get a number today. 1 minute, just somewhere. I know Dr. May.
One more minute, we'll change.
1 minute.
One last minute.
My name is Alice Healy, and I'm with the Sullivan County, New Hampshire Second Chance Juvenile Mentoring Project. We work with adolescents who are in probation and are at very high risk for residential placement. Some of them may get short stays, but we're really not doing re-entry in that regard. I don't really have any questions. We're a very small county. We don't have a lot of agencies to work with, but I think we were very fortunate to have most of the key agencies at the table to start with. We provide therapeutic case management for the youth and for their families. Families are required to go through a 12-week evidence-based family education, family management program.
Oh, that's good.
We provide access to other kinds of psychoeducational trainings as needed, and we work with Big Brothers, Big Sisters to match the youth with a mentor. We're in the early stages of adding the mentoring piece. We've been in place with the other pieces for over a year. And I think it's going well, and I think we've also gotten to the place where some other agencies are actually coming to us to say, we'd like to provide services for your population. For example, we're very close to Dartmouth-Hitchcock Medical Center, and they've got some leading researchers and practitioners around trauma-informed services. And obviously, that would be a really good thing for our population and probably for all of your populations. So they've come to us and said, we'd really like to work with your folks, and it's nice to just have people coming to us instead of us having to go out to beg.
Absolutely.
And I have an idea for you. And also, I just have a question about what this woman said about the psychiatrist coming to the clinic. That really sounds like an ethical problem.
To the jail.
To the jail.
To the jail.
That sounds like a problem with medical ethics for that individual being so arbitrary in the way they're delivering services to clients. Does that raise flags for you as a psychiatrist?
I don't know all the details of that decision-making process.
Or the contract.
What the contract says, and so it may just, what it is an overwhelming need and an underwhelming capacity.
Exactly.
Within that, all sorts of bad things can happen.
But he's on the contract.
I wouldn't want to make any statements about the judgment of that person without knowing what it's just.
And probably the contract.
The contract, he's under contract for that.
That contract was probably written eons ago.
But there's above all else, do no harm. It seems to me that for some of these patients, there may be harm being done.
But my concern is, if you are in that field to help people, and you understand the mechanics of what counseling, psychiatry, I would think, even with the contract, there is a contract in place, and that's what he does. But, okay, how about this? Like I do. I've been here since 6:30. I get off at 3. It's 5 o'clock. I'm still here, and I'm happy. Then, maybe he might, I'm saying what day would he might just say, you know what, are there any more? Is it anybody I can help? I'm waiting.
No,
But
there's
I mean,
lots of people. It's hard to, it's a hard judgment.
Also, sometimes, and I don't know what your situation is, sometimes it's a med psychiatrist where they're specifically there to monitor the medication and not to do the counseling piece of things. Okay.
No, he's there to assess the therapeutic.
Well, I want to thank you very much for a very informative and rich discussion. I think we come away from these sort of learning just as much as you do. So I want to thank you for your comments and your questions. You can find me pretty easily on the Reentry Resource Center website. I'm sort of the main contact for the Justice Center in terms of substance abuse and addiction issues, and can help you get to Dr. Osher as well for mental health and co-occurring questions. So please, feel free to follow up with us. And I think we'll be talking a lot internally about how we can continue some of these discussions and continue to hear from you and be helpful. And again, as Dr. Osher said, the TA opportunities that are available via the Reentry Center were really just an email or a phone call away. So please, please, please reach out to us as you embark on your projects and use us if we can be helpful. And enjoy the rest of the conference.
Thank you very much.
Thank you very much.
Thank you.